Hello, and a warm welcome to everybody joining us for the second session for today's 8th annual ISNTD Water meeting. We've had a great first section in which we were really looking to assess the various linkages to various global health agendas for WASH at a community level, moving to a service orientation, all sorts of kind of issues covered in the first session. One of the key points that came out of that really was this kind of focus really that's needed at the healthcare facilities level. It's certainly something that the WHO have made a big point of this year, and we have kind of picked up on that, and we're very delighted to be joined today by a cross-sectional panel. We've got Dr. Baridueh Badon from Merck, the Access to Water initiative there within the Merck Global Health Institute. We've also got Robel Wamisho, the WASH Program Manager at World Vision Ghana. We've also got Cephas Wedam, who's actually joined the WASH Program Coordinator from World Vision Ghana. Also Bioye Ogunjobi, the WASH Specialist at UNICEF Nigeria. And then we've also got Miss Magdalena Shao, one of the assistant lecturers at Muhas University in Tanzania. And we're going to be discussing really the focal point really of WASH in healthcare facilities for this particular session. It's a very interactive session. If I could ask the audience that have joined us just to give us a bit of a shout out in terms of your name, organization, countries, that would be very, very useful, not only to us, but for these speakers too. I see Dr. Bioye Garang from the Ministry of Health in South Sudan. Greetings and love and peace from Landos. Solomon Wafuola from Uganda. Collins Onditi, I think from Kenya. We've got a lot more attendees in there, so please don't be shy. Give your names, give your affiliation, give your countries, and we'll be weaving in your questions as they come through at the end of the Q&A. I think that's enough from me. I think we'll pass over to the first speaker for the day. And I think we're going to hand the floor over to Dr. Robel Wamisho, the WASH Program Manager at World Vision Ghana. So Robel, over to you.
Okay, thank you for the opportunity. This morning, myself and my colleague Cephas are joined here to share the learning and then the experience of what World Vision Ghana has been doing to address some of the challenges in healthcare facilities, especially in the area of water, sanitation, and hygiene service provision. World Vision Ghana's program in this country, especially the water, sanitation, hygiene program, has a very long history. Since 1985, World Vision Ghana's program has been active in Ghana and then has been serving the communities by delivering services at various levels. Next slide. Yeah, so this morning we want to share the experience from one of the districts where World Vision is implementing water, sanitation, and hygiene as part of the district-wide initiative to provide WASH services. This district-wide initiative, as you know, of recent has been gaining momentum in the sector because of its contribution and an affiliation to the broader SDG agenda. Just by way of a quick background, the World Vision's program in water, sanitation, and hygiene are addressing or implementing in three different settings, that is the communities, schools, and then healthcare facility settings. So this presentation will focus on experiences of our work in healthcare facility settings. And then I will be walking you through a few slides that will explain some of the things that we have done and then the lessons that we have learned from the Asutifi North District. So in terms of location, Asutifi North is, if you can see the map, is around the western south or southwestern part of the country within the Ahafo region of Ghana. And then that is where we have been implementing this WASH program, district-wide WASH program in communities, in schools, and then healthcare facilities for the last 3 years, since 2019. And then we just want to share what has been happening in the healthcare facility setting, along with the implementation has been happening along with other key actors in the industry. IRC is there, Safe Water Network is there, and then the assembly too, the district assembly too is there, Choir Institute is there, and then others, including the CDC, are also there in this journey. So it is a collaborative approach that we have been pursuing. So just a summary of the few interventions that we have delivered. Looking at the water supply, 5 healthcare facilities have received water supply service. And then looking at sanitation infrastructure, we have 3 healthcare facilities that received sanitation intervention, means the toilets. And then hand washing facilities, 7 healthcare facilities have received those services. The waste disposal, we have provided that service across 6 healthcare facilities in the targeted district. So what we are sharing here will give us maybe 3 key objectives, or will help us deliver on 3 key objectives. The first one is we want to share the WASH service progress in targeted healthcare facilities in that district in terms of the JMP service level indicators. So where were we? What, level have we come currently? Where are we? What are some of the changes? What are the impacts? And then what contributed to those impacts? We'll be touching a bit on it. The highlights of World Vision Ghana's experiences, the lessons, as I mentioned earlier, and then the provision of basic WASH services in healthcare facilities. What are some of the lessons? What are the learnings? We'll also look at that. And then the provision of recommendations for improved WASH service in healthcare facilities, and then toward the sustained health outcomes. Some recommendations which we think are very key for anyone who is doing WASH in healthcare facilities. We want to also touch a bit on those ones. We'll be using a desk review information from an assessment that was led by the CDC and then supported by Conrad Clinton Foundation. So that data is now being used as a source data in this presentation. And then some other interviews that we have carried out with staffs, with communities, health staffs, and then all the information that we got from them, including some of the quotations that the health staffs shared, will be shared to the group. Okay, so let me just begin by highlighting some of the insights in terms of the changes that we have seen. When this Universal WASH initiative in Asutifi North District started, we did a baseline survey just to make sure we know where we are beginning from. So when you look at the first set of the service level indicators, the JMP service level indicators for hand hygiene, you realize that in 2018, we are talking about nearly 71% of the healthcare facilities have no service in terms of hand hygiene. And then only 29% had some limited service in terms of hand hygiene service levels. So during the mid-term assessment back in 2020, toward the end of 2020, we realized that now we have 63% of the healthcare facilities have now basic hand hygiene service. And you realize the no service has drastically changed, or it has come down to 25%. Coming to the second set of indicators in terms of the water service level, you realize that when the survey was initially carried out, or at the baseline level, there was no service that was continuously available to the healthcare facilities during the baseline study in 2018. But when you look at 2020, about 88% have basic service levels in terms of water supply. And then the no service has drastically come down. We still have some work to do to reach maybe 100% coverage. Looking at the waste management service levels at baseline and then midline, you still see trends. During the baseline, 57% had no service in terms of waste management, and then that has significantly come down to 12%, and then 88% had now some limited service level. Of course, this is just to show the progress. The project is still going on. We haven't completed. There is some more work to be done to see additional changes and then impacts in terms of what has been happening. But this is just to share some of the progresses that we have seen in this particular intervention. Now, I want to mention a few notable testimonies from diverse people involved at various levels, and then who are stakeholders to what has been happening. I want to quote what the district health director of Asutifi North District said. He said, the hand washing stations and dust bins provided by World Vision are encouraging regular hand washing and segregation of medical waste at the facility. So this is a quote from the district health director. And then there is another one from a principal nurse in one of the health centers in Gambia. And then she said, access to water at the patient treatment areas has made our work much easier. Hitherto, we had to queue with the community members to fetch water from the community standpipe. So another testimony in terms of how the work has been made easier for the nurses who are working in the healthcare facilities. And then there is another one with the for provision of toilet facility at the health facility. I now feel safe, and then anytime I visit the facility and then had to use the toilet. So when there is toilet, there is availability of that facility for people to ease themselves. They don't have to go to the bush like the old times. Sometimes people used to do that in rural context, and then so that is no more there. And then people are feeling safe, health workers are feeling safe, patients are feeling safe because they have toilet facility or access to toilet facility. And then there is another one in terms of community engagement and then maybe testimony from community. The idea to sell the water for revenue has improved our maintenance culture. Either due to lack of funds to fix the borehole, the health facility could lack water for 3 months. So the sustainability angle is another key angle that I want to bring here. Facilities can be provided, but if they are not well managed, if they are not sustained, then that is a problem. So mechanisms should be put in place for the healthcare facility to be able to manage those facilities in a sustainable manner. So that is this community member is trying to say now they are managing their facilities very well. And that is a quote that we mentioned from him. So you can see some of the impact pictures here. The first one shows a nurse washing her hands before entering the facility at the Koforidua Community Health Planning Services, the CHEPS compound. And then the second one, a nurse washing hands at the sink after attending to a patient at the patient treatment area. And then the third one shows a completed solar mechanized system model for the healthcare facility. So it is a handy water system operated by solar energy. It doesn't have to draw energy from the grid or maybe from generator or from any other source. This is a sustainable way of delivering energy or pumping water using solar energy, which is abundant in the region we are talking as far as sub-Saharan Africa is concerned. So and then the woman here is also accessing water from a pipe, which is provided for patients at the for the Gambia healthcare facility. So these are all interesting pictures indicating how staffs, patients, children, pregnant women are benefiting from the interventions that we have implemented. All right, now the before situation and then the after situation, maybe some information on that will also help. For example, when you look at the toilet on the left at the top, this was at Kenya C number 3 CHEPS compound. You can see the situation of the toilet before intervention. People used to come, patients used to come to ease themselves in such kind of facility, which is very risky even for their lives. And then it can also cause serious damages to the health of the people. It can endanger their life. But now, after intervention, you can see what it is looking like. A nurse is washing her hands after visiting a WC toilet facility provided in that same healthcare facility, Kenya C number 3 CHEPS compound. So you realize that the transformation is not simple. There is a marked change. So people are now using water closet. The nurses are using water closet. Patients have access to such a facility, and then it means a lot. It means a lot. And then you also realize that a nurse is fetching water from unprotected well for at the another community health planning services or the CHEPS compound. But now that healthcare facility has been connected to a water supply facility which World Vision provided. And then you can see the same man is washing his hands within the healthcare facility because now they have water, they can wash their hands, They can do whatever they want because of the availability of water. So maybe a few experience and then lessons that we have learned. The first key thing that I want to highlight here is leadership. Leadership is very important at all levels, at district level, and then even at healthcare facility, unit level. If it is a hospital, at the hospital level. If it is a CHEPS compound or a clinic, at all levels, leadership is very key. Taking the lead, taking the ownership, being responsible, holding people accountable for the use, for the management of WASH staffs is very key. So that is one key learning that we have taken from this process. And then transfer or change in staffing in healthcare facilities without capacity building or knowledge transfer plan on WASH may disrupt the process, because some of these people have gone through a number of trainings. They have gone through management training for the water supply facility, for the sanitation facilities. So when they are moved elsewhere without proper engagement, without proper discussion and then maybe arrangement, that can disrupt the process, especially in terms of sustainability of the service or provided. And then the sustainability can be influenced, as you can see on the diagram. Leadership is very key, as I mentioned. Active community participation or partnership is also very key. Capacity building and then knowledge transfer plan is also very key. And then there has to also be a mechanism to generate sustained source of funding to do repair, to do maintenance of those facilities. Okay, so one important lesson that we learned from the work that we did in healthcare facilities in Asutifi North District is the fact that, or the importance of linking the nearby communities to the healthcare facility. In terms of, let's say, you see a water kiosk that is provided here, and then that water kiosk is linked to the healthcare facility. And then the community comes, when they fetch water, they pay for water. Whatever they pay for water will be used to manage and then maintain the water system that is also supplying not only for the community but also for the healthcare facility. So the same model can be used even for other institutions like schools. Sometimes we realize that healthcare staffs think there is no budget that is provided by the district for maintenance. But what else can be done to maybe minimize some of those bottlenecks or problems? So these are some of the innovations that we are doing. We train vendors. We train the water and sanitation management team members. And then we also train the healthcare staffs who can work with these people and then to be able to vend water to the users, to the beneficiaries, to the communities. And then every income that is generated from this process comes back to sustain the water facility. So that is one area that we want to also highlight. It has really helped us. It's still work on progress, but looking at even the graph, you see the revenue has continuously increased over a period of time, and then the expenditure is minimum because they were able to pay for maybe the maintenance costs comfortably without feeling the stress, because the revenue is more than the expenditure, or they didn't have maybe major breakdowns, but whatever they were able to confront in terms of maybe maintenance challenge, they were able to pay for it because they were able to generate revenues that can pay for that through the pay as you fetch approach that we have been practicing in partnership with other agencies, mainly the Acquire Institute. Now, maybe a few concluding remarks. The first one is availability of improved WASH service. It boosts, of course, the health staff morale. You have seen the testimonies and then the quotes that I mentioned earlier, from patients to staffs, district health directors, all are happy and then confident because of the services that are provided. And then also it improves even the safety of the staff and the patient. You saw that toilet that was very, very risky at the beginning, but now the situation has completely changed, and then safety has been ensured. So that is really very key. And maybe the key recommendations that we want to highlight here is considering sustainable options such as water vending services, for example, to augment the finance and then operations and then maintenance of WASH infrastructure in healthcare facilities is very, very important. It may seem maybe not that significant, but when you go and see there's a problem on the ground, it is really important. If there is no proper mechanism to generate revenue, if there is no proper mechanism to ensure the operation maintenance costs are covered, then the water services can be disrupted because of simple minor issues. And then if there is no leadership who is maybe going to hold people accountable to make sure these services are restored, that is also not the best arrangement. So these are some of the things that we want to highlight maybe before we conclude. So these are the partners with whom we have been working, and then we are still working in the Asutifi North District, not only in the healthcare facilities, but also in the communities and then in schools as well. I think that is it. I'm not sure if I've taken longer time. If I have done, I want to apologize, but thank you for listening. Thank you for the attention. Much appreciated.
Robel, thank you very, very much. Absolutely no need to apologize. A fantastic presentation. I love the fact that you kind of honed in onto this water vending, moving from this tech intervention mentality to a service. It was certainly something that was picked up to drive the sustainability of it all. That was certainly picked up in the first session, and we were definitely going to be asking questions around the challenges around that, moving the mentality of people from a kind of into the service mode. You've demonstrated how that can work so well when you link it to HCF. So thank you very, very much for that. And I know that Cephas Wedam, the WASH program coordinator, he will be taking questions because you have to leave in an hour, I believe, Robert. But thank you very, very much for that opening presentation. Thank you. I think it's time to move on to the next speaker in the session. So great kind of the World Vision experience in Ghana. There's some interesting kind of points made, which I'm sure will pop up into the questions in the chat that the audience are going to have and feed that into the questions. And we're getting some questions coming through. already, so thank you for that. And from the audience, we've got such a spread of countries. So from Tunisia, Dr. Mohammed Habib Jemli, assalamu alaikum. Dr. Jemli Philip Odida from Kenya, our own social media manager for Africa from Tanzania, Yona Yangaza. We've got Shahibu Samuel from Liberia. From Albania, we've got Zahida Suleimani, Ilya Nadams, Roloyo Emmanuel from the Nigerian Institute for Trypanosomosis and Onchocerciasis Research in Kaduna in Nigeria. It's fantastic to see this spread. Glasgow, we've got Oliver Higgins from the University of Glasgow's Bioengineering Department. Hi there, Oliver. So fantastic. Dr. Koulibaly from the Côte d'Ivoire, Dr. Fadel Abdullahi from Nigeria, Ethiopia is there as well. A great spread, and it's a fantastic kind of testament to the importance of this particular kind of focal point of healthcare facilities and WASH. So thank you very, very much for that, Robel. I think that takes us quite nicely into the next speaker, Dr. Baridueh Badon from Merck's Access to Water. We've had the pleasure at the Merck Global Health Institute. We've had the pleasure of speaking with Baridueh for several months in several meetings that we've had with the whole team there. Some amazing conversations and kind of insights. And so it'll be interesting to see this presentation. So I think without much further ado, I think I'll pass the floor over to you, Baridueh. To you, the floor. Yeah.
Thank you, Cameron, for the introduction. So greetings to everyone, wherever you are. My name is Baridueh Badon. I'm the project lead for Access to Water in the Merck Global Health Institute. I'm here to quickly introduce you to Merck itself and to our Global Health Unit, the activities that we run, and then also share with you our Access to Water strategy and then the reasons behind these decisions. So Merck is a very vibrant science and technology company. We are over 350 years old, the oldest pharmaceutical company in the world, and we have nearly 58,000 employees working in 66 countries worldwide. We have 3 business units, Merck Healthcare, Merck Life Sciences, and Merck Electronics. In the US, we are known as EMD, and for our healthcare division, we're known as EMD Serono. For our life sciences, we are also known as Minipol Sigma, and for our electronics, we are known as EMD Electronics. In Merck, we have a global health unit being run by Manfred Kleversatz, and where we work with improving health of undeserved populations in low and middle income countries using Merck science and technology innovation in close collaboration with external partners. The global health is divided into 3 other units: the Merck Global Health Institute, which is led by Jutta Rainer-Rupp, the Merck Schistosomiasis Elimination Program by Jonas Vaz, and the Access to Health team by Chris Herrera. I work in the Merck Global Health Institute, and this institute is a translational institute with interlinked pillars. We work around technology, science, and digital in 2 disease-focused areas: schistosomiasis and malaria mainly. For our technology, we innovate technologies targeting prevention of infectious diseases and improving countries' capability to address health challenges. And for our sciences, we create scientific and health care workers' competencies through network of expertise to increase country preparedness. And for our digital, we link technology and science to support data processing, creating awareness, and adaptation of health systems. So all of these approaches are sustainable access models to strengthen health systems. So speaking about our schistosomiasis, we have a schistosomiasis elimination program, which we use an integrated approach. Firstly, we donate every year over 250 million tablets of praziquantel in partnership with WHO. We are also part of the Global Schistosomiasis Alliance, where we advocate and accelerate progress in elimination for schistosomiasis. We also focus on female genital schistosomiasis. It was very interesting in the first session of this conference, where female genital schistosomiasis was adequately dissected and dealt with, and this shows how important this disease is in many countries and is mostly neglected. Aside that, we have a pediatric praziquantel consortium with other partners and pharmaceutical companies, where we are developing a new oral dispersible tablet for children below the age of 6. I'm very glad to let us know here that we have a very successful phase 3 clinical trials for our pediatric praziquantel. And alongside, we are also developing new candidates to support breaking transmission goals. We don't stop there. We are also into diagnostics, where we are working with different partners to develop rapid diagnostic test kits for schistosomiasis, and also an artificial intelligence-based cartocard diagnostics for disease surveillance and monitoring of MDA programs, basically. And of course, we're into WASH, which I would go further to tell you how we in the Global Health Institute are dealing with this, and then health education for behavioral change. Our second disease area is malaria, and you can see clearly there that malaria is strongly linked with WASH too. But aside that, we also have an integrated approach where we have an anti-counterfeiting technology to detect substandard and falsified medicines. We implement WASH in local healthcare centers and communities. We also have set up a Pan-African Virus and Novel network as a center of excellence for scientists to do research and also surveillance programs around Plasmodium vivax and Novel. This network is based in Ghana, but has a network of 14 African countries with scientists being part of the program. In-house in our Merck Electronics division, we have an insect repellent called the IR3535. And this insect repellent is also effective against mosquitoes. So we are currently doing a clinical trial to see the effects, the long-lasting effect through this lasting formulation, to see how effective this is against women and babies in Ghana. For malaria too, we don't just stop doing drug discovery for schisto, but also for malaria, where we're doing research and development activities for new anti-malaria treatments. And our capacity building program is around microscopy. So we train a lot of microscopists on malaria microscopy in Ghana. So we train healthcare workers in this session. So you can see how integrated our approach is, and then seeing that the two disease areas where we work is strongly related to WASH. And so we use this integrated approach in our delivery. And this is further amplified by the new roadmap for neglected tropical diseases by WHO, which strongly advocates that 100% of healthcare facilities or regions should have access to at least basic water supply and sanitation and hygiene in endemic regions. So this really helps to support the SDG 6.1 and 6.2 goals. With that, we really sat down to think about how do we create a WASH strategy, right? How do we link our strategies towards NTD, disease-focused areas? How do we link it with what we do in-house as a company? And we came up with 4 different components. And the first part is access to water. So for WASH itself, we are focusing on water, and we are providing water to healthcare facilities and communities in areas that have very high prevalence or incidence of schistosomiasis, using an integrated approach, right, for disease control and prevention, and also trying to develop WASH, creating washing stations in communities so that it limits the number of times that women and children basically will go to water bodies, to get water for their household amenities. So in that way, it really reduces prevention, or it rather increases prevention, right, for contracting schistosomiasis. And then in the healthcare facility itself, we don't just stop by providing water in the health facility. We also train healthcare workers on schistosomiasis case management, and then generally on infection prevention and control practices, right, for patient safety. This holistic approach doesn't just provide water in the community, but acts as a health systems strengthening approach for disease diagnosis for schisto in these regions that have high level of schistosomiasis. And we know that schistosomiasis itself has signs and symptoms typical to other diseases like malaria and so on. So if healthcare workers themselves cannot diagnose schistosomiasis or be able to separate them, then it is difficult for the elimination strategy. And then we are also involved in implementation research, where we conduct assessments for healthcare facilities in different regions. And don't just stop there, we also include the quality water testing components. In subsequent slide, you see the reason why it is so important to include this component into assessments, as most water bodies, even that are provided in healthcare facilities or in communities, are not safe enough for people to utilize. And we also work on social business models. You'll see clearly from what Robert has have mentioned in his last slides how important it is for sustainability of WASH programs. And if you implement WASH and then have a sustainability strategy, then it means that you need to come back again, and all of the effort and finances put into this process will be futile. So we try to make sure that all of our projects are sustainable. So why are we really focusing on healthcare facilities? There has to be a background, there has to be very striking statistics, and following the GMP reports of WHO and UNICEF in 2020, it showed clearly that 1 in 4 healthcare facilities worldwide do not have basic water services. 1 in 3 in the world also do not have hand hygiene services in healthcare facilities. This was strongly amplified by the COVID-19 pandemic, where many healthcare facilities in the world, even in very advanced countries, had nosocomial infections or hospital-acquired infections with COVID. And then all of this really links to exposing 1.8 billion patients, and including healthcare workers, to risks of infection. And more appalling is the statistics in the least developed countries, where 50% of these healthcare facilities have no access to basic water services, 70% have no access to basic waste management services, and 20% have no access to sanitation services. If you look at it, it's so appalling. And then a health economist, from a health economist perspective, it's shown that WASH in healthcare facilities is actually the best buy that is producing a 50% return on investment on health, right? So for us as an institute and as Merck, we are focusing on the healthcare facilities and on the water supply aspect, because if there's basic water supplies, it's directly links to sanitation, and it also directly links to waste management services. So this really helps to fight infection in healthcare facilities, and also to help using the best approach by WHO, B standing for behavioral change, E standing for the environment, S standing for social inclusion, and T standing for treatment. So all of these components were put into consideration when designing this. So where are we working, and why do we want to work in this region? So we as an institute focus on Africa, sub-Saharan Africa, for our interventions, and we have chosen Ghana as one of the countries for us to implement WASH in healthcare facilities. Last 2 years, we worked in Senegal, where we provided over 40 water supply services in regions in Matam in Senegal, and this time around we're moving towards Ghana. And if you see from this map, from the 2019 report from GMP WASH, it shows that in Ghana, 61% of healthcare facilities in Ghana have access to water services. So there is a huge need or area to address. And I don't know if you can see this slide very clearly, but this is a further breakdown from the same report, showing that these services are more needed in rural areas and in government-owned facilities. So we will be focusing on the rural areas and government-based facilities to improve this limited access to water services to the best optimal way. And then we don't just end there. We try to look into the quality water aspect. In 2017, GMP, alongside other partners, did a comprehensive research on healthcare facilities in 4 countries, Bangladesh, Nepal, Ghana, and Congo. And it was a shocking revelation that improved water services itself were not safe. So from this report, you can see clearly that for all of the healthcare facilities that had improved water services, some of them had E. coli contamination. For Bangladesh, 36% of the water of the healthcare facilities had E. coli, infection in the water itself in the facility. In Nepal, it was more alarming, that it was 74%, in Ghana 45%, and in Congo 40%. So this is why we include quality water testing approaches into our program. So we wouldn't just provide access to water in this healthcare facility, but also make sure that these water bodies are safe and they do not cause hospital-acquired transmission. So this is the general idea we had behind creating this strategy, and we are open to work with partners. We have different partners in different areas, thematic areas in our approach, and we are open to work with different partners in the world to really solve this problem. So I want to thank you for listening, and I'm very open to questions. Thanks.
Thank you very, very much, Baridueh. A fantastic presentation. You're getting a lot of kudos there. Philip Odida from the Kenya saying best integrated approach, vector control and sustainable surveillance as part of the makeup there in terms of the approach. Yona Uganza, best integrated approach for elimination of schisto. A lot of questions have started coming through as well, which we will come to in the Q&A. And I really, thank you everybody for sending those questions in. Please keep those questions coming. We were definitely going to ask them. I've got some in mind myself, but I'll come to that. Superb presentation, some really interesting stats in there and some really interesting kind of linkages really that we can explore, whether that's access to water, whether that's training, highlighting some of the gaps from the previous presentation as well, obviously the research side, as well as this sustainable business ethos, which we really want to kind of get into that. Dr. May Sule, excellent presentation. Thanks for pulling out the stats. So you're getting a lot of kudos on that, and rightfully so. Thank you, Bioye, for that. You'd mentioned in your, the WHO UNICEF 2020 report, and a few weeks ago we'd kind of, we put everybody together in terms of this panel, kind of this particular panel. We reached out to UNICEF in New York, their head of partnerships, Ezra Jerome. I don't know if Ezra's logged on or not, but he's an absolute legend. So thank you, Ezra, for that. And we managed to get together, pull out from there, really UNICEF Nigeria and their involvement. And so that takes us to the next kind of speaker. Bioye, you mentioned that report, and their stats have really hit home, I think, that 50% return as well from some of those stats that you pulled out. And I think it leads us nicely into Dr. Bioye Ogunjobi, the WASH specialist from UNICEF Nigeria. So Bioye, over to you. I think the floor is yours.
Okay, thank you very much. What I want to take us through is our experience as the WASH section, UNICEF Nigeria, in the NTD interventions. For the WASH section to be in NTD, it was at the beginning accidental because everybody thought because we are looking at water and sanitation, we should be able to address some of the issues around NTD. But that was as far back as 1995. But now we see it as a necessity for WASH and NTD to be integrated. And that's exactly what we have done. But I would also like to, next slide, please. Or probably I can do that myself. Okay, I would not want to really bore us with the presentation outline, and I just go straight to what we are doing, that UNICEF-supported interventions to combat NTD spread in Nigeria. Okay, I mean, everybody knows what is onchocerciasis. Now I want to quickly look at the endemic LGAs in terms of the endemicity. There are 774 LGAs, that's local government areas in Nigeria, and all the LGAs have one NTD or another. There are LGAs that have 2 to 3 NTDs altogether, but we also have 583 that have lymphatic filariasis, and then onco is found in 481 communities, LGAs. Now, schistosomiasis in 582, and then soil transmitted airmates in 429. And we are placing emphasis on the 5 commonest entities, and these are the ones that we are looking at the moment. Now, in terms of what we do as UNICEF, we have our primary responsibility exception certificate for the Metizan tablet coming from the US, donated by the US government to Nigeria, to be cleared free. So we use our IDEC for that, and that's one major thing we do, because it's important, you know, for us to know that when anything it warrants duty payment. So, but with our IDEC, we're able to clear those medicine tablets. And then we are also doing what we call mass administration of medicines. Now, when those drugs get to Nigeria, they are kept in the federal government warehouse in Lagos, and then how those drugs get to the different states is partly our business. In some states we fund the transportation, in some we don't. Okay, but we ensure that all the states that need the drugs get them, especially those 12 states we are supporting. UNICEF is supporting 12 states in Nigeria, especially around Oncosia cases and LF, and this funding is coming from UNICEF USA. While the drugs are coming from the US government. Now, we also support community mobilization. There are people in the communities we call community implementers. They are volunteers from the communities who are trained to be in charge of distribution of drugs to the affected households, to ensure that the affected persons are able to take the drugs. And because NTDs are not very popular, probably because the majority of those who are affected by NTDs are very poor, the most vulnerable. So it's not popular even among the key policymakers. So we decided that the need for us 4 years ago, engaging key media practitioners, talking to them about NTD, talking to them about the magnitude of the problems, to talk to the people, also to talk to the government in order to influence policy formulation. Now, we also went into WASH-NTD integration, and that's what we call hygiene promotion. Now, the hygiene promotion component has to do with making effort to change 90% of the communities that are endemic in Onco and LF are practicing open. There is a variation between the practice of entities. So they're working on promoting and sanitation behavior, ensuring that people wash their hands at critical times, ensuring that they're safe at the source, remains safe up to consumption. That's what looked out. That is what we do. Very quickly, I just also felt I should look at why do we actually have to do WASH-NTD integration? Why must we be interested in integrating WASH into NTD? And I felt, let me just quickly put this in for. Because of the transmission, we feel that we need to, while we are using preventive chemotherapy, especially for those who have been affected, we need to also find a way to interrupt the transmission route for new cases. And that's one reason why promoting safe hygiene and sanitation behaviors is very key to us. So I'm not going to bother us on other. So what exactly do we do? As I said earlier on, we promote hygiene at the community level, which also involves training the health workers, in not just at the state level, but also at the facility level. So the facility health workers in all the endemic areas are trained on how to promote safe hygiene, especially as people come to them in their facility, and also as they go to communities to interact with community implementers. We also felt that it's important for us to place emphasis on those who are affected, but around riverine mountainous communities, those who are who are in IDP camps, who are often neglected, not because anybody wants to neglect it, but because it's difficult to reach out to them. And we are also interested in promoting safe hygiene and sanitation behaviors among border communities. The border communities are often left out because they are very difficult to reach. So this is what we do. And I also felt that it's important for us to say that we are working with existing health personnel. We don't recruit new personnel. There are health personnel, there are community health workers paid by the government. These are the people we are working with. It's just that they are going to have management of medicine around, to combat onco to their primary responsibility. This is one thing that I feel I need to talk about. So I try to use this slide to summarize what we do, and that's we engage public health professionals so that at the end of the day, in whatever they are doing, they seem to see the importance of water and sanitation in anti-Decontour interventions. So it's not just about distributing the drugs, it's also about promoting behaviors that will interrupt the transmission. And we also think that it's important to support access to integrated community case management of childhood illnesses. That's also one of the things that we just moved into because we feel that yes, there are community health influencers and they need to be engaged to add this into their primary responsibility. And lastly, we because of COVID, we have also adopted what we call COVID management measures into the work we are doing, not only at the community level, but also at the LGA level, where apart from using the PPEs, they ensure that each household now has hand washing facility. And we also discovered, as I said earlier on, that most of the endemic communities practice open defecation. So we have introduced sanitation promotion using community-led total sanitation plus to trigger communities to begin to build toilets and use the toilet and end open defecation. This is one thing that we have started doing, and it's really yielding results. There is a particular community where that are now ODF, and it's an endemic community. They are now ODF, and we are hoping to see how this will impact the level of endemicity, the level of transmission in that community. Now, altogether, I tried to put a summary, a slide on the achievement, what we see as achievement in the combat of onchocerciasis and LF. And I am happy to say that since 1995, over 500 million treatments have been done, have been facilitated. We have managed to use our IDEC to clear about 2.5 billion and tablets, free of charge, which is really a plus to the federal government of Nigeria. Now, in terms of the health systems, we've been able to engage the existing health systems, the health workers, but they are now strengthened, and they are now able to get in touch with community implementers, and then working together to combat onchocerciasis and LF. Altogether, we have over 16,000 frontline health workers whom we have trained, and we have also engaged to interact with community implementers. Now, there are 26 states that are really making progress when it comes to eliminating onchocerciasis, and we support epidemiological evaluation, and one just ended in Oyo State, and we do hope that the results is going to be fine, and that might also affect how many times people will be treated from next year in such a place. I'm happy to say that there is now a system in place for MAM monitoring, that's mass administration of medicines monitoring at various levels, the pre-monitoring, the in-process monitoring, and the post-monitoring. So this is ongoing, and 12 states have that system domiciled with the NTD team in the State Ministry of Health, in some cases in the State Primary Health Care Development Agency. So we have this as a result of our intervention. Altogether, in the WASH-NTD integration, we started 3 years ago. We've been able to reach out to over 9,000 communities in 12 states. These communities now practice proper hand washing. There are hand washing facilities, the local one called Tippy Tap. Some of them are using kettle to do the answer of the bottle. So this is happening in these communities, and we sincerely believe that as a result of this knowledge, quite a number of issues around COVID have been dealt with in those communities. Now, the public awareness now around the menace of NTD seems to be going well. We have some programs that talk about NTDs, unlike before. That was very unprecedented. Now programs, radio programs, national television now have programs around NTDs. And I must also say that Federal Ministry of Health is doing wonderfully well around that, because now World NTD Day is celebrated in Nigeria now, starting from started last year or so, or 2019, to raise people's awareness to NTD. Now, what do we actually have in mind? I'm not going to bore you with these challenges, but what do we have in mind? We want to expand delivery of WASH services in endemic communities. As I said earlier on, we want to accelerate support for open defecation-free activities in those states. We have included this in the new proposal to UNICEF USA, so that we can target the states we regard as low-hanging fruit among these 12 states for open defecation-free initiative. And then we are also planning, we've got a WASH-NTD training manual, which we just finalized about a month ago. We engaged an NGO to do that, to anchor that. So it's ready, and then we'll be disseminating that, not only to the 12 states we are supporting, but to all the 36 states, and then we do that through the Federal Ministry of Health. And we are also thinking that it would be important for us to implement community-led total sanitation to end open defecation. There are LGAs that are not far away from BNODF. We want to support that. And because we have also seen that some of these measures that are low cost, but they have high impact, and one of them is safe water chain. Community water, safety planning process, and so on. We want to be supporting this in all the endemic communities. But believe me, it's going to cost a lot of money. So what we do is to pilot in at least 2 LGAs per state. So we are likely to have altogether 24 LGAs in the 12 states we are supporting. Thank you very much. That's all. Thank you.
Bioye, thank you very much for that.
Thank you.
Much appreciated. We wanted to involve, we've heard a lot there in terms of obviously, big NGOs or big NGO World Vision, UNICEF would have been obviously next, and then also the private sector and some of the kind of impact points and some of the drivers within their strategies, all very, very relevant. What we wanted to do is also bring in a grassroots kind of activist, kind of the politics and real politic, as it were, that dynamic. So we're absolutely honored today to bring in Ms. Magdalena Shao, water resources scientist and assistant lecturer at Muhas University in Tanzania, to talk about building the water roadmap for guiding WASH in healthcare facilities, the experience of Tanzania.
All right. Thank you so much, Kamran, for giving me an opportunity to present in your conference. So the theme for my presentation is towards a roadmap guiding WASH in healthcare facility, the experience of Tanzania. I'd like by starting showing us the global status as far as WASH in healthcare facilities is concerned from the JMP reports. I've just brought this up to just show us, like, we shouldn't relax. We are not yet there. We are not even halfway there. Still a lot of people lack services when they attend to healthcare facilities, and we know we cannot dismantle WASH. The components. You cannot just supply water and then sanitation facilities are poor, or hand hygiene practices are also poor. In healthcare facilities, it's very important to provide WASH services as a whole, not like dismantling it. Like, you have proper water supply, and then you lack sanitation facilities and hygiene practices are poor. So it should go hand in hand, providing the WASH component as a whole, because mostly the poor are suffering the ones that in less developed countries, that only 50% of the facility had basic water services, as well in sanitation facilities. It's only 20% of the facilities had no sanitation services. As well, in hand hygiene, we are still very, very, very far. So healthcare facilities are the places where people are supposed to go get treatment, and some are even taking their loved one to get treatment. But in turn, when these WASH services are not well provided, it can turn out to be a place where people now acquire acquire different diseases or infections from the health care facilities. So instead of you going there feeling safe, you're coming home with various diseases that you did not have in the first place. So as far as the roadmap is concerned, I believe we're all aware of the United Nations resolution of 2019, which provided stipulated different resolution for member states. So one of the resolution, which is resolution number 2, it spoke about each country or each member state to develop and implement a roadmap according to the national context in order to facilitate the achievement of the SDG number 6. So Tanzania is one of the member states which has adhered to that. So this is where we are as far as sanitation is concerned. We have seen this is according to the JMP report of 2020, and the less developed countries are even at more risk because of poor technologies, and the facilities are not even enough. Again, for hand hygiene itself. So I'll just go straight to the Tanzanian context of WASH in healthcare facilities. So currently, Tanzanian government is implementing a sustainable rural water supply and sanitation for a period of 5 years, started in year 2019 and a financial year 2019-2020. And this sustainable rural water supply and sanitation is a project implemented under the payment for result basis in selected regions in Tanzania. That means when you show results, it's where you attract more funding, and the funding will help you keep on maintaining the WASH services that you have in a region. So this is kind of a motivation to those people who are implementing the WASH services to be aware of where to allocate these funds and to allocate them in a sustainable manner so that they may attract more funding. And they're supposed to show results. Like if they're given a certain amount of money, they're supposed to put WASH services that are really in a good condition to that value, like the value for money is seen. And of course, the objective of this project is to increase access to rural water supply and sanitation services in participating districts and strengthen the capacity of selected sector or institution to sustain service delivery. And again, among other sectors, healthcare facilities are the one among other sectors that are implementing this water sanitation and hygiene in healthcare facilities, especially in rural areas where it's like areas where people are more forgotten. Like these are the areas that are hard to reach sometimes. So most of the services are not reaching there. And again, most of the population is living in rural areas here in Tanzania, and that's even increasing the risk of having a burden of different infectious disease here in Tanzania. So I also highlighted the United Nations resolution of 2019 on WASH in healthcare facilities, whereby resolution number 2 for the member states, it urges all the member states to develop and implement a roadmap according to the national context for them to have something to guide a country in achieving the SDG number 6, which is, we all know that we want by 2030 to have access for all. So Tanzania developed a national guideline for healthcare facilities, which is a scope now. So it has planning and budgeting for WASH services. So the national guideline, which is our roadmap now, has highlighted how a certain region can plan and budget the resources in order to achieve a sustainable manner as far as WASH services in healthcare facilities is concerned. Again, it has a section where water supply in healthcare facilities is stipulated, where it talks about recommended water sources, and this depends on the number of people that the facility is serving. Again, it has minimum water requirements for the facilities, like how many liters should be supplied, depending on the level of the facility, if it's a national hospital or if it's a dispensary. Another thing is water quality standard, which the guideline has stipulated that every healthcare setting should have its water supplied at a drinking water standard. Again, water treatment methods have been stipulated very well in this guideline, which is our roadmap, and then water access and distribution. And this roadmap has stipulated that most of the healthcare facilities should adapt rainwater harvesting for them to be supplemented when the main water supply from the local authorities go down. So this is, again, another thing that has been very well emphasized. And on the sanitation services in healthcare facilities, the flush toilets are the ones that are encouraged and the pit latrines are the ones that are discouraged. But, however, because of water shortage in most of the areas, ventilated pit latrines have also been stipulated in this guideline. Like some of the rural areas where water is scarce, they can still use ventilated pit latrine. Again, the guideline in the sanitation service has stipulated the needs for people with special needs, where women and girls, when it comes to menstrual hygiene management, elder and disabled people, their needs are catered for. So the guideline has stipulated that there should be facility for these people, so that when these people come and get these services, they should also be saved, pregnant women as well. And in hygiene facilities, hygiene services in healthcare facilities, hand hygiene practices has been very well emphasized. I think because it's like serves as the cheapest kind of method for making sure that our hands are clean, and most of the services that are provided in healthcare facilities are supposed to be very hygiene is supposed to be very well taken care. Again, critical moments for hand hygiene are also stipulated in this roadmap. Hand washing facilities and specification, like which specification are they supposed to adhere? And then what about the bathroom, laundry, kitchen, and mortuary? How are they supposed to be hygienically for them to support different people? Cleaning and laundry, as I said. Wash services during emergency, it's also very important, because we saw when we were hit by COVID-19, it's like we're not ready. We do not have like a preparedness plan in place. So this roadmap has stipulated what should be done, which resources should be used, who should do what, as far as the emergency is concerned. Again, control vector and vermin, landscape and gardening, operation and maintenance, as well as monitoring. So in a nutshell, that's how the roadmap for Tanzanian, as far as WASH facilities is concerned in healthcare setting, is very well stipulated. So, as I said, now we are implementing the payment for results. So in Tanzanian context, and in that case, 599 healthcare facilities were assessed to determine their situation as far as WASH is concerned. So out of 599 healthcare facilities that were assessed, 76.62 of the facilities did water supply services, whereby most of them had rainwater harvesting system, as you can see there. And again, surface water was another water supply services that most of the facilities have, again in tap water. But surface water now is very prone to pollution, we all know. So the treatment methods are also very expensive. That's why the guideline has insisted, as much as there is a connection to local authorities, but the healthcare facility should also have a kind of substitute when it comes to water. And for sanitation and hygiene, as much as the guideline stipulates that most facilities should adhere to pour flush or to flush toilets, but the situation is different. Most of the care facilities here in Tanzania have pit latrines, and the pit latrines are very discouraged, as we all know that they are not safe, especially being present in a healthcare setting where it's very easy for infectious diseases to happen. And in terms of hand washing facility, the guideline stipulated that there should be permanent healthcare facilities, not the ones that we improvise where we put a bucket and a tap and wash our hands. It's good to have those, but because of different issues that are happening, especially if we don't have sustainable facilities, issues such as climate change could just happen and ruin them all. So we're supposed to have sustainable kind of facilities for us to operate in a safe manner, I can say. So lastly, what I think I wanted to insist on are ways to improve WASH in healthcare facilities. First of all is to making a case for WASH service agenda. So in most cases, WASH is not like a main agenda in many platforms. It just comes as a by the way agenda. So it's not given the attention it deserves, and that's why it's not even put as a priority. So I urge every member state here, especially in African countries, to make sure that in those big forums, the political kind of forums, WASH is very well taken care of, and it's given the attention it deserves, because we all can agree that without WASH services, we won't reach anywhere. And again, we are aware of how important to have political will as far as pushing for implementation of WASH services in healthcare facilities is concerned, so even the political leaders can be taken on board. Again, designing and implementing WASH programs. It's very important to have programs run in a country. For example, here in Tanzania, we have a program called National Sanitation Campaign, which has brought a massive improvement as far as WASH services in the community is concerned. So it's very important to design and implement WASH services in healthcare settings as well. And improving WASH services in specific contexts. It's very important. These services should be improved context-based, because what works in one area should not necessarily work in another area. So it's important to consider that and put that into consideration. As well, different sources of funding is very important. We should know where our money comes from, and we should know how we are going to allocate that. Strategic partnership, we shouldn't just work ourselves, we should work with other sectors. There should be intersectoral coordination, there should be coordination among different stakeholders in order to achieve what we want to achieve as far as WASH in healthcare facilities is concerned. Again, to integrate safe WASH into other health programs. For example, now we have nutrition programs that are running in a country. We have universal healthcare program. It's also very important to integrate WASH in those programs in order to achieve, to have a massive achievement. And lastly is to set targets within our policies and integrate indicators for safe WASH and IPC international monitoring mechanism. So having said that, thank you everyone for listening.
Thank you very, very much, Magdalena, for that. You know, we really value your input there. It's really interesting to see the Tanzanian perspective on it, and especially this the SRWSS, the Sustainable Rural Water Supply and Sanitation Program that's in rollout mode at the moment. I've tried to weave together a few questions from the audience. They kindly asked that. I'm just going to ask a couple of questions and then, try and bring some of this, amalgamate some of the kind of feedback from the audience as well. That you had some from the firstly, thank you very much, all of you. It was wonderful to hear that session, a very important session. This whole issue of sustainability it has been in every one of your presentations, right? That's been a central theme all the way through. Whether that's sustainability from a leadership perspective, how to maintain standards of accountability, or this issue of staff migration, this legacy gap in terms of legacy of training for WASH as the new staff move through. They move through, that in itself is an issue. Sustainability when it comes to the actual involvement of the communities, moving into the service mentality for water supply. And some of the questions, what I wanted to ask, and I want to weave some of the questions from the audience as well that I have got, so I haven't got that much time, so I'm going to ask you this question now. And so my questions were going to be around the sustainability issue itself in all of its aspects. I was going to go into that road. Dr. Ramadani Bofu from Tanzania, he had asked that in terms of the sustainability plan for the healthcare facility leaderships, how are these actually set? And I think he's alluding to who do you bring into that, the making of that sustainability plan itself? What are the priority settings in WASH facilities? And also another question from Solomon Wafula along the same lines: what are the actual management systems for sustainability of WASH in these facilities? So looking at the leadership and the gaps that were highlighted right at the beginning, actually, by Robel in terms of leadership and then the training gaps within the kind of the leadership setting within healthcare facilities. What are the management systems and how are those plans set? And I think I'll ask, let me just make sure I've got very there. So I'll ask Cephas that first, if possible, from World Vision's perspective. So from your work that you've done, and Robel had actually highlighted this, what were some of the management systems that are in place? How are those plans set?
Okay, thank you so much. Can you hear me?
Yeah, we can hear you and see you.
Thank you. Yeah. So as Robel indicated, sustainability in our project was very key, and then focusing on leadership was the ultimate goal we were looking at. So we began from the district level. We engaged the district team. We drafted an MOU, more like a performance kind of agreement. So in engaging them, we, of course, outlined to them the fact that they need to sustain these facilities. And if indeed, so it was from a demand responsive approach. Yeah. So if indeed they want water, they want to solve the water needs of their communities, of their healthcare facilities, of their schools, then there's the need to hold each of them accountable. So they signed to this MOU, more, as I said, more like a performance agreement.
Yeah. And
that leadership was exhibited by the district team, especially the district chief executive, who was so passionate about this. So we cascaded this MOU down to the facility level, where the facility managers, I'm talking about the healthcare facility, also signed to this MOU. They will ensure sustainability of the infrastructure that is being provided. And of course, key stakeholders were involved in this planning process. We have what we call the community health management committee at the community levels, that is made up of some key leaders within the communities and also the health personnel. So these people were part of the entire process. They were part of the decision making to ensure the sustainability of the facilities. So they were allowed to bring in suggestions as to how they can improve and sustain the facility. So the suggestions were from them. They were homegrown from them. All we needed to do was to document that and put it back to them as MOU, as I mentioned earlier, performance agreement to them. Then we track their performance.
That's a fantastic answer. Really, we're talking about the water and sanitation management teams, and I think that's a fantastic answer. It really shows a sense of listening. You talked about the demand side, Cephas. That's a vital side of it. Expanding on that demand side, but staying within sustainability. I just want to put this question. So we talked about very briefly there about water and sanitation management teams and the plans around that to kind of bolster the way the leadership programs are run and make sure that those gaps in training and accountability are addressed. So that's fantastic, and I appreciate that answer. Moving that listening kind of the demand side ethos outward slightly, or drilling into the community itself, I just want to focus in on a little bit in terms of the actual communities themselves, because we're talking about this. Somebody raised this point about water, clean water vending attached to healthcare facilities. Baridueh, obviously, well, you went through the whole, you showed the kind of really holistic 360 Merck approach to access to water, training, not just the research side, but you also focus on sustainable business. A question that had come in from a social enterprise perspective. So this question is to Baridueh, and actually Beatrice had actually asked this, Dr. Beatrice Greco, the head there at the Merck Global Health Institute. She'd asked a question, and I'm just trying to bring that up actually on the thing. I remember her asking this question. What type of, let me just, bring that up. What is the type of local governance that would fit the best to ensure long-term ownership and decision-making? We've heard about the water and sanitation management teams. How about the communities themselves in terms of social business? What are the challenges that you've seen, Baridueh, from your side, or that you anticipate from your side?
Okay, yeah, so thanks for the question, Cameron. I think that question initially was directed towards Robel, who answered. That was his perspective to his presentation, and his response was specific to the community in which he was working. And then he said, if I can remember when I read the response, was this is important that the local assembly needs to take ownership of this, right? So, but this exemplifies research that has been done worldwide around what really makes projects sustainable, right? Coming from low and middle income countries, we know that there's a lack of resources when it comes to this, and then there's perhaps a mentality where you're giving something and they expect to get more, and then research has also shown clearly that over 10,000 WASH projects worldwide have been abandoned because the communities were not involved in decision making. It's like saying, come to my place, give me water, and then I'm off, right? But once you involve the community into, there has to be a need. The community also needs to see the importance. They have to be involved in all of the decision making process. Do you put this water point in position A or in B, and so on? You also need to go down to look into what's the cost of water. Are there psychological, cultural behaviors around beliefs for water system? There are some water bodies that is a taboo for you to go into, or they perceive water in different ways. You need to clarify all of those, and then the community needs to set up this community approach, or a body where they manage the resources. I wouldn't be gender biased to say women, but of course we know that women are the real caretakers of homes in these settings, and they have to be involved. Different statistics have also shown that it's women and girls who have more the responsibility in getting water for household activities. Therefore, these women needs to be strongly involved in it. They need to set up management facilities or principles that are cheap and affordable. Do you want per service payment or monthly maintenance payment, right? And then you need to also have technology that is that's local, called appropriate technology, and not bringing something from a place that has a Wi-Fi or a drone service, and then once it breaks down, the community cannot maintain. So it has to be a local source, something that's easy to maintain, cheap to maintain, and then this community security, where we know that this is for us, this is our own, right? And then when the community has this full ownership, they set up their own management systems. We pay this, we pay that, we agree on this, and then you have it running. I think the perfect example from Robel for the healthcare facilities is even very interesting. You know, for people who say healthcare facilities are only there for clinical services, but if the water supply to the healthcare facilities cut short from the community, then they wouldn't have services. But for the fact that people usually go to the healthcare facility more often, and they have water they have access to water, it would, I don't know, but maybe I'll be interested in research going forward to see how healthcare facilities that have access to water increases uptake of healthcare services, right? So, or maybe I have a headache, or I was having fever, and then because the water is around the healthcare facilities, I really want to use this opportunity to also seek help, right, from the nurse or the doctor in the place. So community involvement and community participation, I feel is very, very important, and when it comes to leadership in sustaining WASH interventions globally.
I mean, that's a fantastic answer, Baridueh, and I think you don't underestimate how inspiring that is to hear a private sector talking about the actual granularity, the granular level at the community level, and the importance of that. I think that's a really, frankly, very inspiring to hear that, and it's a great. And the overall commitment of Merck into that area has always been in that community kind of optic. It's very much appreciated, by, I think, by everybody. I'll spin that around a bit, because we had a question from Dr. Bioye Garang at the Ministry of Health, South Sudan, and he's asking. I will ask this to Magdalena. He's saying, great presentations and awesome work by all the speakers. The question he's asking is that. From the earlier morning session, there was a concern that WASH programs, when left alone to the actual communities that we've just kind of highlighted, they tend not to be very sustainable or profitable, and that integrating an aspect of private investors makes them more sustainable and profitable. Does anybody have a different experience with this? And if not, does anybody know why that is the case? When private sector can, you just alluded to HCFs and water vendors coming together. So there's a kind of a parallel there that the community then trusts that. There's a trust built up that that water coming from the healthcare facility is clean. They're happy to pay for that. It enters that kind of part of the perception, as it were, the mind. And he's asking really, he's asking quite a long, that common sense would be that community-owned should be more sustainable in the long term. Are our communities engaged enough to sustain and own these processes, projects, and programs? Magdalena, I'll ask you, is there an advocacy gap at community level in terms of the business side of it, the sustainable business side? Do we need to do more to engage those communities? Magdalena.
Oh, okay. Thank you, Kamran. I was also very interested to see that practice where people access water from the healthcare facilities. Yeah. I haven't seen it here in Tanzania. I can say that. I haven't seen such a practice. So that is something I've learned and something that but again, what I'd like to say is I've seen most of the donor-funded projects that cannot go as far as 3 months or 4 months. It's because sometimes we experts tend to go somewhere and just start this project without engaging the community that is present. These people have indigenous knowledge. They'll tell you where they want their service to be put, maybe. They'll tell you the nitty-gritty about their area, how people are living in that particular area as far as behavior is concerned, but we tend not to listen to them. So we design this project for them, we go put this project for them, so they don't feel the sense of ownership. So at the end of the day, when the project now is ready, these people vandalize the infrastructure. They don't care about the infrastructure. That just because they weren't involved in the first place. So I believe if we take them on board from the design stage, when you start designing this project, you go to them, seek the information, get to know how this area is, get to know what they think, get to know how they want their service to be provided to them. I think it will help us sustain these WASH infrastructures.
That's a fantastic answer, right from the grassroots at Muhimbili University. That perspective, that's why we valued you having here. I believe that's very interesting, and I hope there's some cross-pollination in terms of Cephas World Vision going out to Tanzania and this HCF and water kind of relationship being built stronger. Bioye, we haven't heard from you, so I'm going to ask you that.
Yes.
The kind of final question. What are your views? You talked about UNICEF scaling out, and you talked about onchocerciasis, and you talked about lymphatic filariasis. Same community issues in this, or different types? What are your views on bringing the community with you?
Thank you very much. I must say that my colleagues have spoken extensively about the need for the communities to play a major role, and that's fantastic. If the communities are not involved right from day one to be part of the planning, part of all the processes, the project will fail. This is what's been happening. But as important as that is, I see integration of WASH into health as a sector as a major, a very huge investment that really involves government. Government needs to play a major role. We have a guideline for WASH in health facility in Nigeria, and that guideline gives responsibilities to the government. Government at the federal, the state, and also the local government level. This is their responsibility. But when you also look at the huge resources required for this, government alone may not be able to fund all the activities. So what we are also expecting in Nigeria is for the private sector to play a key role. We have a very robust private sector, which we haven't been able to really explore in WASH. So we are thinking that private sector engagement is very, very important. And how do we engage the private sector? Believe you me, all of us jump to the conclusion that private sector must put their money as part of their corporate social responsibility. Yes, I agree. But there's also a way we can present it to the private sector as a way of making money. For example, when you look at management models, community management models, there are places where communities will agree with the third party to manage their facilities, and then there's an MOU between them, and then the third party also makes some money. So it's a money-making venture.
That's a very interesting thing, this for-profit. Yes. I've had to cut you there, Bioye, because we have to go into the next session, because the way the system is configured. I really hope that we have the chance to get you all together for a longer session in the future, maybe in a few weeks from now, if you're open to it. There's so much to unpack. I've made copious amounts of notes while you're all speaking, and I was going to really get stuck into it. But so I'd like to say thank you very, very much to yourselves and the wonderful audience as well for their involvement. Thank you very, very, very much to all of you.
Thank you.
And I really
thank you very much. Bye-bye. Bye-bye.
Yeah.
Thank you. Thank you very much. Thank you.
Bye.
Take care.
Bye-bye.
Bye-bye. Bye-bye.
Bye.